Welcome to Healthbeat, where we take the pulse of South Africa's healthcare system. I'm Mia Malan. About 50 million people, 85% of South Africans, rely on the government health system. Some parts work well. Too many are badly managed and short of staff and resources. Efforts to change our healthcare system have stalled because our government's plan for universal healthcare is now being challenged in court. While the country waits for the Constitutional Court to rule on 2 NHI court cases this May, something else is happening on the ground. In parts of the country, far away from the spotlight, people are finding ways to make healthcare work better. Healthbeat looks at how partnerships are making that possible.
In Ngileni village on the remote Wild Coast, seeing a doctor isn't simple. People walk for hours, cross the river or find money for transport, if they can. Even 5 kilometers can take more than an hour to cover on this rough ground.
When you watch them, sometimes you're like, those potholes in Ivory Park are not as bad.
We don't have a clinic here. We have to travel this way, the 20 kilometers to the nearest clinic, or we have to cross in the big river there, which is Kocha, to go to Nganya Clinic, or we had to go to Mpame and we cross a big forest.
Nosintu Gwebindlala is a deputy traditional leader. Her husband's family has cared for villagers around the Xhoga Mouth administrative area, which falls under the Mbashe local municipality, for generations.
When you're here, for the communities, you are everything. You are a nurse, you are a doctor, you are an advocate, you work for SASA, you work for Home Affairs, you are a teacher, you are everything.
In 2002, Cape Town IT worker Dave Martin hiked this coast with the dream of building an eco-friendly backpacker lodge, using tourism to develop the area and show a way of living that works with the environment.
If you're coming to a community where you don't know anyone, your point of entry is very important. You have to go through the various structures, which is community meetings, put your idea out there, see what the support is, help get communities to select a committee who's going to work with you, make sure it's nicely representative of the different clans and the different sides of the village, for example. If you're fortunate like we are to have very forward-thinking traditional leaders, then that's a great asset.
When the Bulongula Lodge opened after 2 years of talks with the community and government, the project had expanded far beyond the lodge with an education and health program.
By the time they came in, there was diarrhea in the area, like lots of diarrhea in the area. They started fundraising very small for those diarrheas, and that was the birth of the Bulongula incubator.
Half of the mothers in the area had experienced the death of at least one of their children because of diarrhea. Nosintu joined the Bulongula incubator board. Dave and his partner Rajan Woodruff now live here and work to find money from donors to fix the problems people care about the most, starting with education and healthcare.
So BP 137/69.
The incubator, together with the government, pays for 20 onomakaya, or home carers, to go from house to house with measuring tools and children's toys in a backpack. They do health checks to pick up when someone is sick, bring people their medicines, make sure babies have been vaccinated, and support mothers and children with health and learning milestones. It's thanks to the incubator that there's a village health point on the same side of the river where many people live. It cuts out the boat trip they used to have to take. Over the past 14 years, it's grown from a medicine pickup hut into a mini clinic where Sister Pumla Soizwapi can live and work. The government pays half of her salary.
On a daily basis, we used to see more than 55 to 60 patients per day. But as it goes like this, we'll find that maybe like today, we've seen plus minus 15 patients.
The government clinic sends someone across the river to collect medical specimens for testing.
To me, I may say, the program is growing because previously they said it was a pickup point. But now we are able to communicate with the other clinics, referring them and doing most of the services that are done at primary healthcare services.
Today, the community owns the lodge that Dave started 22 years ago and its profit fund local development.
The developing world is littered with projects that look great and subsequently fail. The main failure reason is often the fact that the host community couldn't manage the changes that came, with jobs and income and resources. This project has been held together because the community has, over 21, 22 years, has managed that process very skillfully.
As trust deepened, partnerships have expanded. This year, Nosintu and the Bulongula Incubator have partnered with the Industrial Development Corporation's Social Employment Fund to create 1,000 jobs to grow nutritious food and clean up the environment.
This project came, then shows us this land is something to give you something to eat.
I noticed ever since these kind of projects have started, most of youth are not leaving to go to Western Cape for farm working.
The community's partnership with the Bulongula Incubator has led to much better health outcomes over the years. But most importantly, it has empowered people here to take charge of their futures.
As much as there's data that will show like no more children dying and, people having 100% adherence to ARVs and other chronic meds, more important than that kind of data side is to see how our community here is really now starting to see the fruits of all those years of actually developing their own skills and having young people and older people who actually now are really skilled and doing amazing work.
In Bulongula, healthcare works better today because of partnerships. The community leads and government and a non-governmental organization supports it. That's something that matters even more in a massive hospital like Groote Schuur.
Palliative care is all about partnerships.
We can make the medication a bit stronger. Do you want us to try to make it a touch stronger to see if it helps better, or are you happy how it is?
I'm happy with that.
Cape Town's Groote Schuur Hospital treats about 350,000 people who come in for treatment every year. It's a public hospital under pressure. Some buildings date back to the 1940s, but it still delivers top healthcare. In 2025, Brand Finance ranked Groote Schuur the 26th best university hospital in the world, ahead of many hospitals with bigger budgets in Europe and the US. Now it has received an award from the European Society for Medical Oncology, recognizing how its teams work together to support people with serious illnesses.
The award is saying you are actually providing comprehensive pain control. You are doing all those components when you are dealing with pain.
But for Renee Krause and her team, helping people at the end stages of life is about more than pain management.
Palliative care is not just the relief of suffering, it's the prevention of suffering. So as a healthcare worker, you need to think to yourself, what is lying ahead for this patient with cancer? And what can I put in place to prevent it For example, I know that a patient with lung cancer is most probably going to become very short of breath. What can I do to train the family on shortness of breath?
From hospital specialists to community health workers, all the way to patients' homes, nobody works in silos.
Palliative care is all about partnerships. When we are working with a patient and a family in turmoil, we've got to sing the same song. We mustn't have conflicting messages.
People with incurable illnesses need support in every part of their life, both physically and spiritually.
The most common symptom we deal with is pain, and then the other common issue is what's next. What's happening with you socially, what's happening with you psychologically, what's happening with you spiritually, all contributes to how you are actually interpreting the pain you have. We look at things that give meaning to people, give meaning to patients. Sometimes it is a relationship with a deity, but not always. And we need to hold families and patients when they ask, what has happened? Why me? For example, when we see young women and they've got incurable disease, are we talking about who's going to look after those children? Does the school know what's going on with that child? How are we going to hold that child and contain this child during this turmoil in their lives? Oh, dignity is a very personal thing. And what gives me dignity is not the same thing that will give you dignity. We must never assume that dignity is beautiful hairdo and clean nails and something. It's that things that you need to explore that will give the person dignity. Most people will say to you, I'm more dignified if I can go home when I'm with my people. And that is difficult when I'm in my own place.
Oh, okay. And your mom here,
So they want to die at home?
Not everybody, and we must be very clear that most people want to actually pass away at home, yes.
And that means that you have to train people at home how to take care of them.
And that is difficult because we have very little time, and that's why our community healthcare workers become so important, and our nursing sisters in the community and our hospices in the community become so important. We need to depend on our community healthcare workers and our hospices to do some of that training as well. So that's why it's so important when you diagnose a patient to link them up with their local CHW community healthcare workers and their family physicians.
Morning. How are you?
Doctor!
How are you, sir?
Hello,
Good,
doctor!
Mama.
Doctor!
Right, the pain is there, but it can't go. We can make the medication a bit stronger. Do you want us to try to make it a touch stronger to see if it helps better, or are you happy how it is?
I'm happy with it.
Now we are working very hard at training family physicians in palliative care, and then also making sure that at each community healthcare worker center, we have a core person that we can refer to. For example, in Dunoon, the leader of the team is a social worker, really doing amazing work with the support of a doctor, but she holds those family meetings, she supports them. You know, it's all of these kind of networks that we need to develop to hold patients.
After the break, health partnerships in the Northwest Province.
I'm becoming more mature. Like all those seniors who were there before me, I'm maturing mentally.
The road to Gelukspand District Hospital runs through what was once the homeland of Bophuthatswana. It screams of neglect. It may be a different era, but the challenges continue. Staff shortages, crumbling infrastructure, medicine stockout.
My name is Kitumetse Mate. I am the CEO of Gelukspand District Hospital, which is located in Mahikeng local municipality. Our hospital is based in a rural setting where patients often travel long distances to access specialized care.
Before democracy, families who couldn't care for relatives with disabilities often sent them away. One such place was here at Gelukspad. After 94, 28-year-old German-speaking Lutheran missionary Undina Rauter joined the therapy department and became its head.
We offer physiotherapy services in the traditional sense. We have an OT looking at aspects of activities of daily living, psychological coping. We also try to cover some communication challenges as our speech and hearing services.
This is the Parent Guidance Center, or PGC. It's run solely on government funding. Mothers in the community named it Reagona. We can.
Oh, just is okay.
Undina's first years were spent studying Setswana. Today, everyone calls her Matumelo, Mother of Faith.
It changed the whole world. When you stay longer, you earn trust. And you will get a lot of referrals from the community because they trust your service.
The therapy team works out how to help patients in affordable ways, teaching families to do therapy at home. They even have courses for moms of toddlers with cerebral palsy and run training groups with them every week.
If you see a child with a disability in isolation, you will not achieve anything. So you need the family context, you need the mother to buy in and embrace the child. We had CP courses where this kind of learning and empowerment was a full-time program for several weeks, and in that process mothers really became strong advocates for the children. They became able to do therapy. They taught us also what they learned and how they manage.
Another way of getting the biggest bang for the community's buck is to schedule as many appointments as possible on the same day.
People have to sacrifice and some hire cars to come here, which cost them 300 plus just to attend therapy. And we try to accommodate that by giving a full package on that day with all professionals we have available. Coordinating our therapy and doctor's visits and making the session long enough that it is value for money.
In Lutlakane village near Mahikeng, we meet Gineilwe Dikoma, mother to Lerato. She was 16 when she had him.
It's my first born. I didn't know for the first moto disabled mo botshelong ba me ana salle a 6 months antse ke mo isa clinicing for physically on gona le system wa ntare no tshwantse ngwana ka 6 months aba adula so abantare ke mo ise go Gelukspad ke mo leto la rona le simoletseng go nna teng ke bona di gore gona le batho ba different
no yana o onse yang you shift once more.
Or ne ban cancela ne ke nna ne ke se sharp mara ba mpa mo fatshe ban tlhalosetsa gore ngwana o ntseng yana ke ngwana o ntseng yang ke simula ke sa amogela sentle but at the end of go morago ke simula go amogela gore yes ke na le ngwana o disability tshwantse ke mo tlhokomele.
Gineilo's gratitude and acceptance rubbed off. Other moms also rely on the unit.
This is a PVC. Yes.
Lerato is now 31 and fighting with a modified wheelchair that doesn't fit anymore, but is the best he can get at the hospital.
Because ona le ditlhokego tse dintsi like bona like wheelchair ya re sokodisa. Ha re khone go nna le position ha ke na shelter gore nna nka re ke tsamaye ke Cape Town or go teng re mise go di-specialisting.
Like Lerato, people with disabilities using ill-fitting wheelchairs can develop sores from sitting in the same position for too long.
We had a period where we saw many and very severe pressure sores from the neighboring school, and we started with awareness programs and workshops.
It's paid off. This young man was 10 when he lost the use of his legs. Today, Puriso Mwepadira is a rising star in the Gelukspan basketball team Mongoose, named for an animal that's speedy and agile.
Like I say, I'm growing up, I'm becoming more matured. Like all those seniors who were there before me, I'm maturing mentally.
I think the wheelchair basketball gives them much more confidence, and it's an ability sport. The disability totally falls away. It's so fast, it's so challenging. We started with old hospital wheelchairs, which we fixed up, and yeah, I had quite a journey.
Team GBT Mongoose recently traveled to Gauteng to compete for a place in the National League. Vustile Ruba is one of the team's top scorers, helping them reach the next round.
It's my DNA. This is, for me, there's nothing else. I don't see myself doing anything else. It helped me also with the upper body strength to build, to have muscles and be able to push my chair.
But this team's commitment needs a boost.
We need sponsorship, definitely. We need new wheelchairs. We don't have a court at present. We are squatting at the courtesy of Northwest University, Mafikeng campus, in their facility.
But the thing money can't buy is trust. And that's what's made the therapy unit's partnership with the community fly.
Disability is definitely not about fixing things. It's about finding leverage for ability to unleash.
South Africa's health system does face real pressure. But where people work together, things work better. These are the places people can rely on. How do we make that happen more often? Let us know what you think at health@bekasisa.org.